You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 17th, 2021. Today, two announcements: PFO Closure, Trans-Mitral Procedures, yoga, and a year-end review. First, an announcement. This Week in Cardiology will take a 2-week break for the holidays and return on January 7th. I want to thank all of you for your support and comments. It means so much to me that you listen. I speak into this mic every week, and I never know who it reaches. Remember, it really helps to give This Week in Cardiology a rating and a review on whatever podcast app you use. Also, when you disagree with me, let me know in the comments section on theheart.org Medscape Cardiology. The first topic today is PFO Closure. JAMA has published a really nice meta-analysis of the PFO closure versus medicine trials in patients with cryptogenic stroke. First, some background. Cryptogenic stroke is more common than you'd think, and it's weird. You think, why would this person who is relatively healthy, devoid of risk factors, and in sinus rhythm, have an embolic stroke? Now, the goal is obviously to prevent another one. Since these patients are usually young, the therapy has to be for a long time, which is an important factor. Now, your thoughts immediately go to the possibility of a PFO and paradoxical embolism of clot from the venous system. But here's the problem. Up to 25% of normal humans have a PFO. So it is hard to tell if the patent for anomaly is the cause of the stroke or an innocent bystander. Devices have made PFO closure possible via a percutaneous approach. And PFO closure has been studied in not one, but 6 randomized trials. Now, you can break these trials into the 3 before 2016 and the 3 after 2016, and they have different features and different results. The pre-2016 trials, Closure 1, Respect, and the PC trial, the short story was that PFO closure trended better, but when taken together, were basically null. And in 2016, the American Academy of Neurology recommended against routine PFO closure outside of a research setting. Now, the possible reasons these early trials failed to show superiority of PFO closure included A, low event rates leading to low power, B, the inclusion of patients with TIA and older patients who had competing causes of stroke. Of course, that would be unaffected by PFO closure, and C, some of these trials had mixed medical arms that also included oral anticoagulation instead of just aspirin. Now, the 3 newer trials were more selective and they kept medical therapy as aspirin. Gore Reduce, Close, longer-term follow-up of Respect, and a trial called Defense all found PFO closure was superior to aspirin. Now, there were caveats. Event rates are low, absolute risk reductions are small. 2 trials had significant amounts of missing data, so you wonder about the play of chance. Further, the most positive trials, the ones with the larger shunts, also had the least use of anticoagulation. Thus, one is tempted to think, were the later trials positive because of the better selection of patients more likely to benefit, or were they positive because aspirin is an inferior comparator to oral anticoagulation? Okay, with that background, let's get to the JAMA study. The idea of the authors was to take individual patient-level data from the trials, put them together to get an overall treatment effect, which, of course, that's not that novel. It's been done before. There's lots of meta-analysis. The novel part was then to use 2 risk scores for determining the likelihood of PFO being the cause of the stroke. The risk scores are named Rope and Pascal, and they test whether these scores produce heterogeneous treatment effects, or HTE. Now, I realize heterogeneous treatment effects is jargon, but the idea is simple. A trial includes patients with tons of individual characteristics. There's men, women, younger, older, large PFO, smaller PFO, diabetes, no diabetes, etc. Then the trial takes all of these patients with all of these characteristics and produces an average effect size. Now, in the case of this meta-analysis of PFO versus meds, the yearly incidence of stroke with medical therapy was 1.09% and with device closure was 0.47%. The hazard ratio is 0.41, and this is a 59% reduction that met statistical significance. So you could say PFO closure reduces the risk of stroke by 59% in relative terms and about 0.5% per year in absolute terms. But now you want to know if the patient in front of you is likely to get that average benefit, or perhaps more or perhaps less. And this is where the authors tested these prediction scores. The ROPE stands for the Risk of Paradoxical Embolism score, and it's on a 10-point scale. The higher the score, the more likely the PFO was to cause the stroke. For instance, you get 5 points in the ROPE score if you are 18 to 29 years old versus only 1 point if you're 60 to 69. That's because younger people are more likely to have PFO as a cause. And you get 1 point for being a non-smoker or having a cortical infarct, and you get 1 point for not having a history of hypertension or diabetes, which are risk factors for regular stroke, vascular stroke. Now, the main limitation of the ROPE prediction score is that it did not include any features of the PFO itself. So the Pascal system takes the ROPE score and adds echo-derived shunt size and presence of an atrial septal aneurysm to the ROPE score, because those factors increase the odds that the PFO was causal. Pascal reports 3 criteria for PFO causality: unlikely, possible, and probable. Okay, so now let's look at how these scores affected the results of the meta-analysis. And we have to consider both relative and absolute risk effects. For patients with a ROPE score less than 7, the hazard ratio of PFO versus medicine in all the trials was 0.61, and for the ROPE greater than 7, the hazard ratio was much more significant at 0.21. The translation: the relative risk reduction was greater for those with clinical features that suggested the PFO was causal in the stroke. And the p-value for interaction was significant at 0.02. However, that's relative risk reduction. You also have to look at absolute risk reduction. And here the absolute risk reduction in lower ROPE scores was 1.1%, with confidence intervals that span 0, so not significant. And for higher likelihood ROPE scores greater than 7, the absolute risk reduction was 2.1%, and both favored PFO closure, but the confidence intervals for the lower ROPE scores crossed 0. So again, better risk reduction in patients who had higher ROPE scores. Now, let's look at the results using Pascal, an arguably better score because it takes into account both clinical and anatomic and functional characteristics of the PFO. In patients graded as unlikely, there was no reduction of PFO closure versus medicine. The hazard ratio was right at 1.0 on the no effect line. For patients graded as possible, the risk reduction of PFO closure versus meds was significant at a hazard ratio of 0.38, a 62% reduction. And for those graded as probable, the hazard ratio was 0.10, or a 90% reduction. Now let's look at how unlikely, possible, probable Pascal scores affect the absolute risk reduction in stroke. For unlikely patients, the absolute risk reduction with PFO closure versus meds was null, and for possible and probable patients, the risk reduction was statistically significant at 2.1%. Before I offer my comments, there is another important aspect of this meta-analysis. These risk scores also predicted a harm of PFO closure, namely atrial fibrillation. It is well known that PFO closure increases the probability of AF, most but not all of which occurs in the short term. So the absolute risk increase of post-periprocedural AF with the device was 4.4%, 1.5%, and 0.65% in the unlikely, possible, and probable Pascal categories, respectively. In other words, those least likely to benefit based on unlikely scores were also more likely to get AFib after 45 days. Now, my comments are, I love this study and the idea of personalized evidence-based medicine. And trials are important because they show us average treatment effects in a large group of patients, but within that trial, there are going to be patients who benefit more or less than the average. In reviewing the methods of this trial, I came across a superb review from primary author David Kent from Tufts. It's in the BMJ, and I'll link to it in the show notes. It's open access. In that review, Kent and his co-authors explain the limits of the usual way of looking for heterogeneous treatment effects, which is subgroup analyses based on a single feature, say age or gender or diabetes, no diabetes. Now, we usually see these subgroup analyses in figure 3 or 4 of most of the study publications. Kent and his co-authors explain that these subgroup analyses are fraught with problems and highly likely to be false positive results, mainly because trials are barely powered for the treatment effects of the whole group, never mind these small subgroups. But in this paper, in JAMA, they have individual patient-level data from 6 trials, and they explored HTE in not one characteristic, but biologically plausible and previously validated risk scores. Basically, they looked at results of PFO versus medicines based on what the attributable fraction of the PFO was to the original stroke. Patients with a high attributable fraction of the PFO did better with closure, which you'd expect. Now, of course, this paper has limitations. First of all, stroke after a cryptogenic stroke is a very low incidence event. The absolute risk reductions here are small, in the order of 1 to 2%, and there is substantial missing data regarding the prevention of disabling stroke. Now, on Twitter, I heard from some medical statisticians who were worried about the dichotomization of the ROPE score at 7. Theirs was a complicated criticism that centered on how to combine within trial and across trial variation. It's a variant of the Lord's paradox, and I'll include a link to that. The other limitation has nothing to do with the analytic method, but has to do with the best choice of medical therapy. Now, since the likely mechanism of stroke in PFO is a paradoxical venous thrombosis, clot, and the best treatment of venous thrombosis is oral anticoagulation, an argument could be made for oral anticoagulation as the proper comparator. You wonder how a trial of PFO closure would do against, say, direct-acting oral anticoagulants. Now, the JAMA paper also has a great editorial from Robert Ye and Dorian DeFerrio Ye, where they outline the ideal scenario when a patient presents with cryptogenic stroke. They advocate for very important and common sense things like a thorough evaluation for other sources of ischemic stroke, especially AFib, echo imaging of the atrial septum in consideration of sinus venosus or ASD defects. In other words, make sure it's the PFO. Once a PFO is found, the next step is to characterize the proclivity for paradoxical embolism. Then, and I think this is key, you put all this data together during a multidisciplinary meeting with neurologists, hematologists, cardiologists, echocardiographers, interventionalists, and you come up with a summary of findings, and that can be brought to the family and patient for shared decision-making. It's always a tough call, but the addition of these risk factors to better define a likelihood of benefit of a device over aspirin seems like a very important thing to do. I love this paper and I would appreciate any other comments from experts in the area. Next topic today are transcatheter mitral procedures. Now remember the saying, science tells us what we can do, trials tell us what we should do, and registries tell us what we are doing. And Jack has published the latest update from the STS ACC TVT registry. The registry included data from 2014 to 2020. The total numbers, about 34,000 transcatheter edge-to-edge repairs like MitraClip and 3,600 thereabouts transmitral valve replacements. Edge-to-edge procedures have gone up tenfold since 2014. Most of these are for primary mitral regurgitation. However, there's been an increase in use for secondary MR, 7.6%, in 2016 versus 21%, 1 in 5 in 2020. Now, for edge-to-edge repairs in 2014, the 30-day mortality was 5.6, but in the last 4 years, from 2015 to 2019, the 30-day mortality ranged from about 4.1 to 4.8%. Not much changed. Over the study period, there have been no significant changes in the rates of stroke, mitral valve reintervention, new onset AFib, new dialysis requirement, vascular complications, or major disabling bleeding. Again, surprising that these things haven't improved over time. One limitation of the registry is that there was a fair amount of missing data. When you look at one-year data, 25% of the patient's mortality status was unknown. Now, just a few comments. 38,000 procedures is a lot. I went back up and looked up the evidence base for transcatheter edge-to-edge repair in primary MR. The Everest trial comparing percutaneous repair to surgical repair had 279 patients. And for secondary MR, the positive COAP trial had 614 patients, and the null MITRA FR trial had 300 patients. I mean, is that enough? I'm asking here. I would have thought there'd be more evidence. I mean, I looked at the guidelines, and the only citation for transcatheter edge-to-edge repair for primary MR was the Everest trial. And actually, percutaneous repair in that study was the inferior procedure compared with surgery, but it did have fewer adverse events. Now, I'm totally sure that percutaneous mitral procedures are helping selected people. But as an outside observer here, it seems like a pretty weak supporting evidence. I'm happy to be corrected. Any structural listeners out there, let me have it in the comments. Of course, the medically conservative view would be that you have to have strong evidence for benefits before widely accepting a procedure. Next topic today is yoga. Yoga and vasovagal syncope. Jackie P. has published a small but really cool study looking at yoga as therapy for patients with vasovagal syncope. The authors are from New Delhi, India, first author Gautam Sharma. Now, I'm terrible at yoga, but I think it's a fantastic and uber-healthy pursuit. Did you know, for instance, there are 2 RCTs of yoga for the treatment of patients with AFib, and both were positive? I'll link to them in the show notes. The mind-body connection is hugely underrated in medical practice. This study was fairly simple and elegant. Patients with documented vasovagal syncope were randomized to yoga, a standard care. The primary endpoint was the number of episodes of syncope and presyncope at 12 months. And the mean number of syncopal or presyncopal events at 12 months was 0.7 in the intervention arm compared to 2.5 in the control arm, a statistically significant result. Quality of life at 12 months showed significant improvements of all syncopal functional questionnaire scores in the yoga arm. Now, regarding the yoga intervention, you might wonder, what is it? Here is one of my favorite sentences from a medical journal this year. Quote, "The yoga module was further validated by 5 yoga experts of national repute." I love that. Now, there were 8 supervised yoga sessions in the first 2 weeks, after which patients continued practicing yoga at home for at least 5 daily sessions in a week. Then there were 2 supervised follow-up sessions in the second month, and then 1 guided session per month till the 6th month. The authors include beautiful descriptions of why yoga might benefit patients with vagally mediated syncope. I mean, it could work through central or peripheral mechanisms. Yoga enhanced vascular and muscular tone, especially in the lower limbs. Not only blunts the venodilation phase of a syncopal episode, but may also accelerate the venous return. And yoga breathing and relaxation techniques have been shown to increase vagal tone and improve autonomic balance, and that could potentially curtail the sympathetic overdrive phase and interrupt the activation of the mechanical receptors, which is a critical step in this whole vasovagal syncope cascade. But here's the thing. It doesn't matter how it works. What matters is that it appeared to work. And right now, there are no great options for young people saddled with this condition. Now, of course, this study had oodles of limitations. It was open label, compliance was self-reported, and yoga in India might be also of higher quality than it would be in, say, Middle America. And yes, of course, we should have more trials testing yoga for this condition. But I ask you, why wouldn't we try this as a therapy? I mean, I'm going to keep this study handy and offer it up as a possible thing to try. Also, mark my words, my friends, future generations of clinicians will be perplexed at why cardiologists gave such short shrift to mind-body connections. Final topic today is the year-end review. The Heart.org Medscape Cardiology has posted my top 10 stories of 2021. Take a look and see what you think. Use the comments section to tell me what you liked and what I missed. I mean, I've already received some positive reviews and some hugely negative reviews online. See what you think. Surely there were more than 10 important stories, and you might have other ones that you think would have been better. Also, check out the year-end summary from real academics, Bob Harrington and Mike Gibson. These are very smart people, and they have a wealth of trial experience. I'll see you all next year, and happy holidays. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating and review. That helps others find us.
You're listening to This Week in Cardiology from theheart.org on Medscape.